low number. So in what we try to make, we try to get that both the systolic number, which is the top number, and the diastolic number is lower than a certain goal. The goal to have it for people below 60 years of age to be below 140 for the top number and below 90 for the lower number, and for people above 60 below 150 over 90. So the diagnosis of the blood pressure depends on checking the blood pressure. Blood pressure, high blood pressure is not something that gives you symptoms. So unless you check it, you will not know that you have high blood pressure. It should be checked at least once a year. And a diagnosis of high blood pressure cannot be made on one single reading that is above the goal, but should be made in several occasions when the value of the measurement remains above that goal of 140 over 90 or 150 over 90. So how do we check the blood pressure? So basically there are blood pressure measuring devices, which initially it was this kind of device that's it's called sphygmomanometer, and it depends on creating pressure above the on the arm, above the artery. We inflate the cuff until the pressure in the cuff is above the pressure in the artery. And when that happens, the blood flow stops, right? And then we start to gradually decrease the pressure, and we measure when the blood starts to go. When the pressure in the cuff is right at that peak pressure, that's what's the top number, or the systolic pressure, that means that there's enough pressure in the vessel for the blood to start flowing again, so we can start hearing the blood going again and creating turbulence as it passes through the artery. So we know that's the systolic number, or the top number. And then we keep measuring it as we are deflating the cuff till we get to the point that the blood can flow all the time. That means the pressure now is in the cuff is below the bottom number, which is the number at which the blood can continuously flow and restore its laminar flow within the artery, so it stops making the noise, and that's the bottom number. Obviously, if you're doing this at home, nobody uses this method anymore. Everybody pretty much uses the electronic blood pressure cuff. So a few things are very important about blood pressure, about electronic blood pressure cuffs. There is two kinds that are commonly used, one that's used on the wrist and one that's used on the upper arm. So the ones that are used at the upper arm are more advisable, more accurate, and better blood pressure. So if you're getting blood pressure measuring device for your home, try to get the one that's used at the upper arm. Two, the size of the cuff is very important. The size of the cuff should cover about 2/3 of the upper arm. It's very important to get an accurate measurement, that you get a cuff that is appropriately sized for your body. Three, it's very important to know that after some time they lose their accuracy. So it's important at least maybe once a year to try to take your device and measure it against usual sphygmomanometer and make sure that your readings are still accurate or reasonable compared to, say, your doctor's measurement. And three, it's very important that you should measure the blood pressure when you're relaxed and to have the arm supported, and before measurement you should be sitting for about 5 minutes. Okay, that way you get an accurate blood pressure. Usually we advise most people to check the blood pressure the first thing in the morning. After they wake up, they get a little rest for 5 minutes, have the arm well supported. It shouldn't be like hanging down. They should not be standing. They should be sitting down, relaxed, with their feet supported. And after that, they check the blood pressure, and that will be a blood pressure they use. If it's elevated and they're concerned about high blood pressure, they should take that on several occasions. Usually the blood pressure varies through the day. It decreases for about 15% of its value through the night, and then it peaks through the morning between like 7 all the way to around noon. But still during that peak time, it still should be in those normal values that we were talking about, below 140 over 90. Otherwise, then that treatment is needed. So as I said, if you can see on the right side, like in the early hours of the morning, it will peak. Then it will be a little bit lower through the rest of the day, and then normally it will go down during the sleep time. So there are three different types. I mean, we're just going to talk about three main concepts that you should know about the blood pressure. The primary hypertension, by far, is the very most common type of hypertension. Usually happens in adults between age of like 25 to around 55. And it's the disease by itself. They just have blood pressure. It's not a result of any other process that is driving it. And we advise lifestyle modification. We'll talk about that briefly in a little bit. And then if that does not work to get it to goal, then we go for medication. There is another type, which is called secondary blood pressure. And it's always important when you have blood pressure that's outside this norm. This blood pressure can be secondary, driven by another abnormality, like people who have tumors in their adrenals, they have Cushing's syndromes, people who have abnormal thyroid function, all different kind of diseases that like stenosis in the renal arteries, renal diseases can have a secondary blood pressure, and in those type of blood pressure depends on what is the cause that's led to the hypertension. The concentration will be on treating the main disease, which will result in curing the high blood pressure. And then drug-induced, some medications can cause increase in blood pressure. The most common ones that we always try to educate people about, they're very commonly used, are NSAIDs, or the non-steroidal anti-inflammatory medication people use for usually joint pain, like ibuprofen and all the trade names of it, Aleve, Motrin. These medication can cause increase in the blood pressure. So through times, we change different goals. The one column I want you to concentrate on is the column in the very middle, which is JNC8. So, and that's what's currently used as a guideline to decide when to treat blood pressure. So a normal blood pressure for people less than 60 years of age considered to be less than 140/90. More than 60 years of age, less than 150/90, and less than 60 years of age, less than 140/90. When these numbers are crossed, that's when we try to intervene. This falls into the general population. For patients on dialysis here, we do not have a very clear idea where exactly should their goal be. The one thing that is very important to mention that depends on what other diseases you have, the type of medication may matter, particularly for people with CKD, diabetes that have a chronic kidney disease. From their diabetes, we try to have their blood pressure controlled via being on an ACE inhibitor, like lisinopril, which is very commonly used, or ARB, like losartan. And then the controlling the blood pressure in those cases is very important for controlling the kidney, for slowing the progression of the kidney disease. Uncontrolled blood pressure really accelerates the effects of the diabetes on the kidney and can result in quicker loss of the kidney function. So hypertension, for the primary hypertension, we don't have a very clear one single factor that we can blame it on. It's a multifactorial disease. Risk factors are, incidence increases with age. It's more common in African Americans than in Caucasians, and it's usually a worse disease as well in African Americans. And then obesity, it runs in family, and it's more common in people with lower socioeconomic status. Why do we care about the blood pressure? What are the complications that can happen if the blood pressure is not controlled and goes not controlled for a long time? It's the leading cause of strokes. It can affect the retina, which is the part of the eye that processes the image and sends it to the brain. So the effect on the retina can lead to worse vision, can lead to blindness. It's leading cause for heart attacks. It's leading cause for kidney disease, and then it causes peripheral vascular disease. And peripheral vascular disease causes narrowing of the vessels via accelerating the atherosclerosis, and that results into inability to use the extremities. Like they get like intermittent claudication. If you're walking, you can't walk for a long distance. You get pain in lower extremities. Sometimes if you get an ulcer because of ischemia, people can lose limbs due to that. So those are the main complications that happen when the hypertension is left uncontrolled. So what are the symptoms? And this is why we really like to educate about high blood pressure, because in general, there is no symptoms. It's very rarely that you get, or it only will be symptomatic when the blood pressure is way too high. So usually if the blood pressure is getting to 160, 170, and happens over a period of time, and it's not treated, then typically the patient will not feel anything. It will only be found on the, if we're checking it. The symptoms that can happen of headache, blurry vision, having an episode of bleeding, intracranial bleeding, epistaxis usually happen on a very high blood pressure. Sometimes it can cause shortness of breath, can lead to heart failure. But typically, we try to educate people about checking their blood pressure on a regular basis, so hopefully they will never get to the point where they have unchecked blood pressure for a very long time and present already symptomatic. And then, or they present already with a complication of untreated blood pressure like strokes or heart attacks, kidney disease, or vision abnormalities. So as we said, it's a multifactorial disease, so what do we do about the treatment? Just like the disease is multifactorial and we don't really blame it on one single reason, there's many factors that affect it. It's trying to work against every factor that contributes to the disease, help getting the blood pressure under control. So we encourage physical activities. Physical activity, we try to advise people to have aerobic exercise of about 30 minutes for at least 5 times a week. So that's a total of about 2.5 hours a week, but they should be distributed in that order. We advise about the diet, increase your intake of fruits and vegetables, decrease your intake of salt, and try to lose weight. Losing weight helps the blood pressure. If you drop the weight for about 10 pounds of weight loss, can translate into about 10 points of systolic blood pressure reduction. And then obviously smoking is a big risk factor for worsening blood pressure, and it also independently increases the risk of atherosclerosis and accelerates the disease. So stopping smoking, and if none of these work, then we advise treatment with medication. So as we said, weight reduction per every 10 kilograms, it's 5 to 20 points on the systolic blood pressure reduction. DASH diet, which is basically what we talked about, rich in fruits and vegetables, limiting the sodium intake to about 2.4 grams of sodium per day, which is 6 grams of sodium chloride total. And then increasing activity, and for the purposes of talk, I think hopefully there's no drinkers here. And then, so the main thing to avoid is salt. That's the most important intervention you can do. And limiting it to about 2 grams and sticking to the DASH diet, just confirming the same concept. Okay, so what is DASH diet? So DASH diet is basically a diet that's emphasizing on whole grains, and in this slide it does tell you what are the recommended daily servings of that. I think the most important part here is limiting as much as you can of full fat dairies. Try to stick to the low fat and stick to the or non-fat like skim milk as much as possible, and try to limit the meat serving to about two or less servings per day. And obviously, in place of that, increase the intake of whole grains, vegetables, and fruits, and use nuts for snacks. When these interventions do not work by themselves, and we add medication. Actually, they should go hand in hand. So even if they do work, even if somebody requires medication, they still need to continue to do their non-medical treatment for that. So there are several classes. So as we said, the blood pressure is a product of the stroke volume of the heart, how strongly the heart is pumping, and then the tone in the vessel, and the volume of the blood that is being pumped. So the medications, all of them kind of counter these 3 mechanisms one way or the other. So the beta blockers are very commonly used. Your doctor may prescribe things like metoprolol or carvedilol, and the way they work is that they decrease the inotrope properties of the heart, which is how strong the heart is pumping the blood. And it also, so their main side effect that they can cause a little bit of a slower heart rate. People so here I'm basically going to concentrate on what are side effects that you will commonly encounter on these, and then people can complain of some fatigue. ACE inhibitors, so one of the main mechanisms that is mediates the elevation in the blood pressure is the renin-angiotensin-aldosterone system, which is a system by which the angiotensin is produced and it causes the constriction of the blood vessels, and aldosterone is induced, which causes absorption of salt and water in the kidney, so increases the blood volume, and by that increases the blood pressure. So the ACE inhibitors and the ARBs are medications that basically block that system, and by that allow for less inducement of the vessels contraction and aldosterone to absorb salt and water in the body. ARBs like losartan and valsartan are the most commonly used. They're very benign medications. ACE inhibitors are very well tolerated. They have two main side effects of inducing chronic cough and at sometimes causing angioedema, which is swelling of the tongues and the airway. Sometimes that can be very serious. If that side effects develop, then patients should never go back on ACE again for the rest of their life. The diuretics, the way they work is they block the kidney's ability to absorb salt and water, and with that you lose volume. Decreasing the volume, it also affects the blood vessel tonicity and how strong the blood vessel is the tone in the blood vessels, and they drop the blood pressure by that way. Also, the tone in the muscular layer of the muscle also related to the calcium. So calcium channel blocker decrease that tone in these muscles, relaxes the blood vessels, and also decrease the blood pressure. And there are direct vasodilators that dilate the vessels, drop the blood pressure. Most commonly used are hydralazine and minoxidil. On the medication, the couple of things that I wanted to mention that are very important and very commonly used. People who use NSAIDs, as I said, very commonly, that can cause increased salt and water retention, and can worsen blood pressure. So unless there is really good reason to use them, try to avoid using them. Use them as little as possible, as occasional as possible. And Tylenol for just regular pains, muscle strains and things like that works just fine and is more benign medication. And the other medicine that also people commonly used are decongestant, which has pseudoephedrine. So these can cause worsened blood pressure, particularly in patients who are already hypertensive. So if you were to pick a decongestant, try to not have the ones that have pseudoephedrine in them. And then also be aware of some of the weight loss drugs. Licorice and coffee can cause elevation in the blood pressure for about 30 minutes after each drink. So be aware to watch your consumption of that. And that can, particularly if you're hypertension, try to watch how much you're taking, because that can increases the blood pressure. Okay, so as we said, it's basically like more for questions and answers. So I wanted to see if you guys have any questions. Correct. You should not be alarmed, or there is no, the way we should say, there's no indication for a treatment if you are, unless you're consistently above that number on at least like 3 occasions when the blood pressure is the measure that the way I'm telling you, you're relaxed, well supported, arm supported, and you're consistently crossing that number, whether on the systolic, which is the top number, or the diastolic. That's when you need to, an intervention needs to be done. If you already have a good lifestyle, like you're already watching your diet, you're already exercising, then maybe it's time to start medications right away. And the goal is just to get it below these numbers. Okay, I mean, our goal is not to like bring it really, really low, just to keep it below these numbers. If you are not, then that's probably your time to start doing the lifestyle modification. And if you're close to that and you don't do them, it's advised anyways to do them. I mean, this healthy lifestyle is good anyways, like whether you do or you do not have high blood pressure. So if you're getting close to these numbers, just doing that will get you far away from them, and will help prevent you from having values that need intervention and treatment. Okay. very low blood pressure is an issue, but there is a little bit of something that we do not quite understand. People who are very low blood pressure from the get-go, they do not have any disease. They just come in with a low blood pressure. So we do not really know if that's necessarily a harmful thing or not. But very low blood pressure that's induced by medication or by an illness, that's just as bad as having very high blood pressure. It's kind of the mortality is kind of a J-curve. If you drive somebody's blood pressure with medication really, really low, their mortality increases. Just like when they have a high blood pressure that's totally non-controlled. But that's different than talking on, some segment in the population that will come in and, particularly young females, their pressure already is running at a low side without any otherwise reason to believe that they have any kind of disease, and it's not artificially driven to that level. That's probably okay. So as I said, in the primary hypertension, it's multifactorial. Probably the genetics plays a huge role in the blood pressure, like it runs in families. And then all other things that can, obesity contributes, unhealthy lifestyle, all these factors contribute. But we cannot really blame the primary hypertension on a single factor that you can take care of and eliminate disease. That's why it's called primary. In other words, it's like a fancy word to say we do not know. If it's a secondary high blood pressure, like, as I said, if it's something like driven by abnormal thyroid function, driven by abnormal secretion of corticosteroids in the adrenal gland, if it's related to renal artery stenosis, if it's related to kidney disease, then that's a different story. But the vast majority of people with hypertension, they have primary hypertension. Does that answer the question? So when the diagnosis is made, the person who has the disease should be evaluated, right? I mean, that's how it's made anyways. It's like you're measuring your blood pressure, it's not normal. Your doctor's checking it at least once a year. You're going to the doctor, he's checking it, and then he's telling you need to come back for a check, and they find out that you have high blood pressure. They get a very detailed history. Sometimes there are clues in the history that indicate that maybe there's something else wrong, All of a sudden, the onset of very, very severe hypertension, like all of a sudden, someone who's been following his primary care for a very good time, and then one time he comes in, he's very high. He's having, episodes of like dizziness or having episodes of having flushing and a lot of sweating, then all away, then they go away, and during the episode, the blood pressure is very high. That can be associated with adrenal tumor that can be secreting catecholamines called pheochromocytoma, for example. People who are like otherwise healthy, they reach a real late age, and all of a sudden they have a new onset of a blood pressure. That's something else that can point toward that maybe there's a secondary cause for it. People who all of a sudden gain a lot of weight, and they have other marks to indicate that they have like I was saying, Cushing syndrome. They produce a lot of cortisol through their adrenal glands. Those marks, when your doctor makes the diagnosis, he usually will go through a detailed history to make sure there is nothing else to point that there is a secondary cause for the blood pressure. Plus, the right population, the right timing for the blood pressure, the right pattern of the blood pressure elevation, then the diagnosis of a primary versus secondary can be done. And some things we always test for. If you need to, yes, like say, you have a blood pressure problem, you're taking the medication, it's okay, but for otherwise healthy, do not have a problem, at least it should be once every few months. Their actual recommendation is once a year, but most people will take to check at least once every few months. If you're young and otherwise healthy, through your physical once a year, that should be enough, unless there is a reason to do it more often. If you're taking the medicine, most of the time you end up needing to check it more often. That's something. Once you're in the medicine, it's something that your doctor probably will need to give you some guidance about how often to check and how often he wants to check it, depending on how you're doing. If he's doing any changes and things like that, then he will decide. Like say someone that his only problem is high blood pressure. He's on one medicine, Every time he comes in, he's very well controlled. After it started the blood pressure medicine over the next few weeks, he's checked it, and he's always at goal. Nothing else going on. There's probably not a need to keep checking it every week. But for adjusting medications, if there is something else happening, you need to go to the hospital, things like that, then we probably check more often just to make sure that you're where you need to be. They disclaim pretty much everything that is reported, which ends up being a huge amount of side effects. Number one, not all people are going to experience those side effects. Number two, their incidence is a lot less than the actual benefit from the drug. But it depends, sometimes a particular person will have a particular complication, like, for example, as we said in the angioedema with ACE inhibitor. It's still a very good drug. The vast majority of the time we use it, there's no problem. But it can be a serious side effect, and it can happen. But they do disclose very, very commonly, and sometimes if you're like, if you read the side effects for any drug, you probably don't take anything at all. I mean, obviously the only reason we give it because we totally believe that the benefit outweighs the risk. Yeah, okay. High blood pressure not necessarily causes the kidney stone. There is a little bit of association. It's kind of very weak association, not a very, nothing that you can really like. Depends on the disease, but if you get like, say, CKD from that, then that can cause blood pressure, which is, CKD stands for chronic kidney disease. All right, okay. Thank you everybody for coming. You guys have a good evening.